there's a reason we're talking about gender today. This is women in MPN, and why have a women-based day for a disease that affects both males and females? And this really relates to some factors that I noticed, all of us have noticed as we started studying these diseases more systematically. I've been trained and been practicing at Johns Hopkins now for 25 years. And actually, when I was a resident, so during my training, the first case presentation I did was regarding polycythemia vera. So this was in the 1990s. And so I became interested in the disease before I became a hematologist. But before me, at Johns Hopkins, there is William Osler. And William Osler is thought to be the father of modern medicine. He was the founding physician at the Johns Hopkins School of Medicine and the hospital. And there he is, a picture of William Osler writing his textbook. And he wrote the first textbook in the United States called The Principles and Practice of Internal Medicine, where he gathered medicine together. And he highlighted and coined the term polycythemia vera. So he identified the disease, or what he thought was a new entity, and he called it polycythemia vera because it was a disease where people had too many blood cells, too many red blood cells, but they didn't have a reason for overmaking red cells because of low oxygen or heart disease, which was sort of the concept then in 1905. This was 100 plus years ago. He was not the first to report the disease or describe it. That was polycythemia vera was described by Vaquez, but he was the first to describe cases in the English language. He went to Europe and presented these cases in the new entity in English, and then he devoted a chapter in his first textbook about polycythemia vera, and he coined the term polycythemia vera. So, you know, we at Hopkins, we claim everything, right? We discovered everything at Johns Hopkins. It's all ours. Now, I know you're going to be getting a talk from Dr. Hobbs and Harvard discovered, but right, you know, I got right. So anyway, but particularly, right there. And there is a picture of William Osler, who is describing this as an entity. 1905 was when the textbook was published, and where he wrote in the dome is still there today. So even though it's in such a distant memory, it really is on my path to the outpatient center every time I go to clinic. Okay, and now we have, that was 1905, and in 100 years, we have the French report of the discovery of the JAK2 mutation. So in basically 100 plus years, right, we have the first description of an entity saying, I think this is a disease, and then the molecular pathogenesis. So it's really quite remarkable, and it really goes at the top again. We've got Osler and then the French description, but down here we also, at the time when William Osler wrote, well, the first description of a gene and chromosome was postulated by these two nice males. By mid-century, the structure of DNA was really being defined, and this is Rosamund Franklin's X-ray crystallography that aided Watson and Crick to define the structure of DNA, and this is her beautiful photo showing the double helix. And then finally, the Human Genome Project, right, where we were finally able to decode our whole human genome in year 2000, published. So again, the knowledge is in lockstep with the technology, right? You can't discover a gene if you don't know that genes exist. You can't understand whether a disease is a genetic cause, whether it's acquired or something you were born with, until you understand the structure of heritability and the way that genes even exist. So, when we talk about Osler's days, we're talking about clinical descriptions and a hypothesis of how a disease is formed. And now we understand the genetic basis of medicine and how that can drive diseases. So a little bit of context to Hopkins. This is, I started my practice in my training. Oh yeah, here it is. Right, here's the JAK2 discovery, and what this graph is a graph of basically knowledge expansion. So this is the number of papers about myeloproliferative disease published per year, and this is just downloaded from the National Library of Medicine. You can see not much going on in the myeloproliferative diseases, and then after the 2005 discovery, now we're sort of in this real uptick in terms of research and reporting, which is very exciting, and we all have to kind of catch up with this information as both doctors and patients. So it's a good time to be informed. Okay, so as Dr. Michaels mentioned, 2005 was the discovery of the JAK2 mutation, and we often use this term, acquired somatic mutation, meaning, right, this is a change in a gene, right, but it's not something that you were born with or that you're going to pass along. So we talk about genes and heredity, of course, your eye color, your personality, all these traits that you can pass along that are through genes that we call constitutional, make up your constitution. But this is an acquired mutation of a gene, and we say acquired somatic. You'll hear that often, meaning it's acquired in the body. And as Laura showed us, right, the way stem cells grow and are instructed, they're instructed by cytokines or hormones like erythropoietin or thrombopoietin, that a cell binds this on a receptor, and then inside the cell, this is now the signal transduction machinery that includes JAK2, you can see it right here, and it sends this signal once a hormone is bound inside the cell to tell the cell to grow or differentiate. Right, so we all need JAK2. The JAK2 gene and the JAK2 protein, we absolutely need it to grow cells, so you can't live without JAK2. So it's not a bad thing. The only problem is when this mutation occurs, it lets the cell signal about 5% more than it should. And I use the analogy, it's just a little bit of an overachiever. So it signals a little bit more than it really should when it gets a signal, and it gives a growth advantage to the cells. And I always like to use analogies also in my practice. 5% or 2% doesn't really sound like too much growth, right? Extra, right, growth. But we know that a change in your mortgage rate of 1 or 2% over 30 years, right, ends up being a lot of extra mortgage payments. And if you think about the number of divisions, right, every time the cell is dividing and you have this disease for years, that does end up being a lot of extra cell production, okay? So what the mutation does, right, it gives you an enhanced growth activity, and it gives a growth advantage to the stem cells that have that mutation. So 2005, this discovery, and the original reports described it in polycythemia vera, but we quickly learned that, gee, you know, you could find the same mutation in basically 3 different diseases: high platelets, essential thrombocytosis, polycythemia vera, or primary myelofibrosis. And what this Venn diagram is trying to show us, if you could imagine all the JAK2 V617F positive individuals in this black open circle, if you then said, well, what are the phenotypes or the clinical diseases that encompass everyone with JAK2, the majority of people who acquire JAK2 have P. vera, but then a good proportion of patients with ET have JAK2, although not all of them. You can see some ET patients here don't have the JAK2 mutation. And that's similar to myelofibrosis, that some have the JAK2 mutation and some don't, as the diseases lay over the JAK2 spectrum. We also have this overlap, right? That there's some people, I've overlapped ET to PV because it's not uncommon within the JAK2 world. If you have JAK2 positive ET, that maybe after 3 years or 5 years or 20 years, your red cells start climbing also. So it doesn't mean that the doctors were wrong, that I've had PV all along. It's just that the disease has evolved a little bit, and now you fulfill criteria for PV. And that's similar. PV can evolve or have features of myelofibrosis in this direction also. So there's a lot of overlap here and a lot of heterogeneity. And I think of blood diseases, this is the most modifiable disease by other factors, right? So all these individuals within the black circle here have the JAK2 V617F mutation, yet there's quite a bit of variability of how it's translated in their body in terms of the disease they're experiencing. And other diseases like CML, chronic myelogenous leukemia, don't have this variability. You get the BCR-ABL oncogene for whatever reason, and you get CML, and it doesn't matter if you're young or old or male or female, you get the same disease with the pretty same natural history. And this is very different, where, well, it does matter if you're young or old, if you're male or female. So it's very modified by age, gender, and time. So as I mentioned here, one mutation, but many different diseases. And we really need to understand these factors that drive the variation. I want to touch briefly on the second most common mutation in MPN, acquired somatic mutation of CALR or calreticulin, because many of you in this room may have the CALR mutation. So CALR is the second most common mutation after JAK2 V617F that we associate with myeloproliferative disease, or we call that the driver mutation. Then the third most common, which is pretty unusual, is the MPL mutation. But both of these, CALR and MPL mutations, impart a similar growth advantage. So even though it's not a mutation of the JAK2 gene, these mutations seem to phenocopy or copy the same excess signaling that the JAK2 imparts, so that again, it gives an advantage to the stem cell that has acquired the mutation and lets it overproduce cells. All right, this discovery of CALR was in 2013, so it's even more recent in terms of the knowledge and the research that we have to try to understand the difference. If I make a Venn diagram of CALR, here's, again, if you can imagine in this black circle, all the individuals that you could gather that have the CALR mutation. And you can see within that CALR mutation group, there's some ET patients and some myelofibrosis patients, but very rarely actually does PV cross into the CALR world. And I would like to ask my colleagues, I've never had a patient who really has P-Vera but has the CALR mutation. Dr. Michaels has got one. Okay, so it is possible, and that's why I put the little overlap, right? Right, and again, this variation, well, why the same mutation, yet I've got ET and the gentleman next to me has myelofibrosis. We have the same mutation. What is that difference? And then also this overlap in that sometimes you can have ET for years with CALR and then evolve into a myelofibrosis phase. So again, there's lots of variation here that we really need to understand. Okay. So this is just a table to try to organize our thinking. If you have polycythemia vera, the driver lesions, meaning the causal lesions, primarily are JAK2 V617F or JAK2 exon 12, slightly different mutations. And again, a very rarely CALR mutation. I didn't even put it up there. I guess that's wrong. But really, if you have the diagnosis of polycythemia vera, if you don't have a mutation in JAK2 or CALR, I think you should really question whether you actually have that entity polycythemia vera. And as Dr. Michael said, maybe there's something else, because this really is defined now by the genes, mutations, and not by a clinical diagnosis or a word. If you have essential thrombocythemia, the mutations, the most common is JAK2 V617F, but then CALR and MPL. And then we do have some individuals who what we call are triple negative, meaning they seem to have a myeloproliferative disease where they're making too many platelets, but we don't know the genetic driver. They test negative for these three. And so again, if we can put a genetic driver mutation about to 80 to 90% of patients with ET. And then in primary myelofibrosis, again, we have the drivers JAK2, CALR, and MPL. and that combined frequency, like ET, there are still some individuals with primary myelofibrosis where we don't know the primary driver or the genetic cause. Okay. Okay, so back up to why did I get interested in gender, or why are we having a gender meeting here for a blood disease? And when I started my research program, I was doing patient-centered research. So I was seeing patients in clinic and signing them up with an IRB-approved protocol. We were banking their tissue. We were trying to understand the cause of the disease, study their stem cells, right? So I was making this patient database. And the strange thing is that I kept getting percentages of 60% ladies or 70% ladies with P. vera in my own database. And that was a strange thing because if you read the old textbooks, they say polycythemia vera is a disease of middle-aged males, and the average age at onset is age 60. And yet, I had these ladies who were in their 30s or 40s or 50s, and more ladies than men. And people would say, well, you just are seeing these ladies because you're a woman and they want to, women go to the doctors more, women get blood work more, right? There must be some bias or ascertainment bias. And this was really sort of plaguing me, right? Because I would try to go to national meetings and present this information, and people just didn't believe it, right? But again, I'm not convening this meeting here of women, someone else is, so I think there's a real issue here. Okay, so what I'm showing you now is, and I do want to mention that William Osler's first report was of 3 patients of this clinical entity P. vera, and one of them was a woman in her 40s that he described. So even back then, right, this effect was there. Okay, then maybe it's a Baltimore effect. That's the other thing. It just must be Baltimore. You're under some big cloud, right, of women MPN. Okay, all right. Here we are in Chicago talking about this. So I want, recently we closed our database, so, and we've been doing a really wonderful controlled study looking at gender differences. And this has been initiated with Dr. Stein and now some more recent fellows. And we have a patient database of 630 patients. And what I'm going to show you is the tables of, they were all seen between 2005 and 2015. And we've organized, they've all been tested for genetic causes. And I want to show you this adjusted model. Okay, so of our 630 patients seen at Johns Hopkins between 2005 and 2015, for everyone, the age at diagnosis is 50 years, but a very broad standard deviation of 16 years. And females comprise 384, which is 61% of the group. And their age at diagnosis is 48.8, compared to the males at 52.9. And this is a highly significant p-value. So again, right, I think we all see ourselves here, and that yes, women do present younger than males, and there's quite a broad range that I'll show you in a bit. People always ask, well, are there racial differences, right? And so you can see all the patients, JAK2 disease or polycythemia vera, however we're going to call these entities, has been described in all racial groups across the globe. In our population, the racial representation represents the individuals that our city serves. So the majority of our patients are Caucasian, 86%, about 10% African American, Hispanic, and Asian, 3%. And that really reflects kind of our national average. And there's no difference between females and males in terms of the racial distribution of the entity. So again, we have more females than males, but you can see the racial breakdown really isn't that different. The only significance was that we seem to have more African American females than African American males, and but that's really kind of it. So bottom line here, women outnumber men in MPN, 61%, and women present at a younger age. Okay, so I wanted to show you then a breakdown of just, this is the breakdown of age at PV presentation. So on this, these are females in our cohort and males. And I want to direct, these are the, so if you were diagnosed at the age of 5, which is the youngest individual in our cohort, she was diagnosed at the age of 5 years with JAK2 V617F PVR, she falls in this bin. So this is a decade, how old you were at diagnosis from the age of 10, and here up to the late 80s. And you can see females, we have a very broad distribution of age at presentation of PV. Right? Again, the median is about 50, but you can see a huge variation in distribution. Whereas males, same issue, age at PV presentation, we see quite a different histogram here. Where, yep, median age is later in the mid-50s. And again, if you look at the right side of this curve, 60 and beyond, it looks very similar, right? Females, right, it drops off with age. But if you look at the left side, whoops, we have a very different story, and many of which you are living. And that, wow, below the age of 40 or below the age of 50, very uncommon in males, yet very common in females, right? So there's a really big difference. Why do we have these young females compared to young males with P. vera? And this is something of critical importance as to what is this difference. So this gets to the question of, well, where do mutations come from? Like, why did I get this? And I always discuss with my patients that MPN patients are the nicest, healthiest people. They are. Like, it's not, MPN are not diseases of lifestyle, or they didn't, go to their primary care doctor, they didn't do this, they smoked too much, or they drank, like, it's not a issue of something that you did or didn't do. And so why, and particularly young women, why would young women get this kind of problem? So it does get to the question is, well, why did I get this mutation? And along the time after the 2005 discovery, other groups started looking at populations quite broadly, looking for mutations in blood cells. And this is a beautiful study that's really opened our eyes to mutation development. This was from the New England Journal in 2014. And what the study did was looked at thousands of DNA samples from blood from individuals who don't have a blood disease. They were enrolled in big studies looking at genetic basis of heart disease or genetic basis of eye disease or lung disease. But they just had tons of DNA samples that they tested for blood mutations. All right, so these were banked studies that were the government had enrolled tons of patients. Researchers went back and looked at, gee, let's see if people get blood mutations at low levels in their bloodstream. And then what they're showing is that, yes, the age of the sample when it was taken and the frequency of these mutations. And you can see as people start getting older, the population gets older, you start to see a real uptick in the number of mutations just with age. Now, the frequency here is it's like 0.4%, right? So it's a low number, but you can see, again, with aging, people were getting this. And JAK2 V617F, the same mutation that gives us MPN, is the 5th most common mutation that the individuals found in this disease, in this study. So that's one issue is, yeah, we get mutations as we age. And then among persons greater than 60 years, males had an increased likelihood of having detectable mutation as compared to females. So again, if you looked at the male graph of this, it would be higher than the female graph. And so again, this is at odds. Well, wait a minute. So I'm saying that mutations are a consequence of aging, and males have a higher risk with aging to get mutations. Yeah, I just showed you that younger women tend to get JAK2 disease than males. And right, there's a contextual difference here. So I don't have an answer to this. I'm just telling you, right, we've got some more explaining to do here. That was a study that was done, as I said, from deposited DNA samples from like 200,000 individuals in the United States. Another group, and many of you may have participated in this. So 23andMe did an MPN study a few years ago where they enrolled patients from the internet, and I think the MPN Foundation had encourage this, right, which is great. Right, and so they enrolled, I think about 700 or so individuals with MPN, and you would enroll, send in a saliva swab, and they did your 23andMe background as a freebie. What they also did was they put the JAK2 mutation on their assay panel. Right, 23andMe is looking at just genetic chain variation that you're born with, or a constitutional thing, and give you a report and tells you your risk of heart disease or all sorts of problems. But they said, well, we'll put the JAK2 V617F mutation on our panel, and then they looked at 252,000 of their regular cohort. People have submitted saliva samples and they reran the JAK2 SNP. And you can see here they found some positives. So just in their reference population of 252,000, they found that 0.2% of individuals had the JAK2 mutation. And again, when they stratified by age, like that last study, you can see it's very unusual, 1 through 30 years. But as they got into 61 through 112, 70, that made up 70% of the positive individuals, okay? Another study here, this was the Copenhagen General Reference study. They had 10,000 individuals in Copenhagen, where again, they were not blood disorder patients, they were just DNA samples from clinic visits. And again, they found the same thing, that you could detect the JAK2 mutation overall at a very low percentage of the population, 0.17%, but the distribution again was highest in the older individuals. So, but the interesting thing here is in these general population studies, again, the female percentage of the positives, this low rate, again, was only 41% in the 23andMe group and 28% in that Copenhagen study. So again, females are far less common than males to have acquired JAK2 mutations that we acquire with aging, this aging group. But again, when the 23andMe group looked at their MPN cohort of 726 patients, they were all JAK2 positive because they were recruited because they had an MPN. Again, the age distribution, like the general population, yeah, it was more common as you got older, but again, the peak was about ages 46 to 60. And again, the female percentage in this was 69%, right? So again, now you can say, well, this was, only women like to submit samples through the internet, women with MPN, right? I mean, all right, how many ways, right, okay, right. That's what people say to me, right? Well, women participate in research a lot more, that's why you're getting this. I think it's really a biologic effect, right? Okay, so females are greater than males in the JAK2 MPN surveys, whether they're done at Johns Hopkins or 23andMe ascertained. Okay. So these are the observations. Women get MPN more commonly than males. Women develop MPN at a younger age. And this is counter to the older age and male predomination of mutation risks in general, right? So what are the implications, right? These are the facts. These are the observations. So what's the implications? Well, the implications that there's risk factors for getting MPN are different for males and females. So we have the male MPN risk factor, meaning you're older, and maybe you've had toxic exposures, right? Males tend to get mutations in cancer at higher rates than females. So maybe in one context, in the older context, that explains males. But the other context is females have a particular risk for getting MPN at a younger age that we don't understand. And so we just can't say that, oh, you got a mutation, sorry, bad luck, right? There must be some risk factor that we need to understand and quantify and do something about. Okay, so the next part of this is, the presenting characteristics, right? So again, if we look at our population, all the patients here, we can see the most common presenting disease was polycythemia vera, was ET. And here, 41% of the individuals. But if we now look females versus males, females alone, yes, ET was far more common. It was 53% of the individuals. Whereas in males, the most common phenotype or presenting disease was polycythemia vera in red here. And this was highly significant. So again, while we still have more females than males, it's the distribution as to how they present is a little bit different. Females more commonly with ET and PV, males more commonly with polycythemia vera. And then importantly there, right, if we look at myelofibrosis, about twice the presentation for males with myelofibrosis compared to females. And to show this in pie charts, and one of my patients said, "Oh, Dr. Moliterno, you love your pie charts." I love that. Again, if we look at if we put everyone into a pie chart, females present as ET, PV, I'm sorry, all the patients, right? The blue means ET presentation, PV, red, and gray is myelofibrosis. That's everybody, but again, if you segregate females from males, you can see the picture is very different. Females with ET and PV, and males with PV and myelofibrosis, right? So the clock is really different for males starting compared to females. So again, the observations are that gender influences the type of MPN at diagnosis, and women tend to develop less aggressive MPN, ET, and PV compared to males, at least at presentation. So what are the implications there? Risk factors for getting MPN are different for males and females. Females have a particular risk for getting MPN that we don't understand, and males carry higher burden of disease at the start compared to females. So, this is a female conference. Of course, we care about our male patients too, and so I wanted to put in a plug for them. Okay, how about outcomes? Let's look more at this database. We have outcomes that we can look at in our group are venous thrombosis, that means deep venous thrombosis in the legs or pulmonary embolism in the lungs, or splanchnic vein, so-called Budd-Chiari syndrome, hepatic or splenic vein thrombosis. We have arterial thrombosis, we mean stroke, heart attack, transformation to myelofibrosis, transformation to leukemia, and we've even now started to look at death in our cohort. And again, we have the percentages here and the significant values. And I'll just go through these briefly. I think Dr. Stein's going to talk more extensively about thrombotic events, so I just want to touch on that females, particularly 15% of our females have venous thrombotic events compared to only 6.9% of males. So again, that turns what we generally understand about thrombotic events in the general population upside down. Males tend to have higher rates of venous thrombosis than females, and yet in this disease, females are bearing that higher burden. There did not seem to be a difference in arterial thrombotic rates between males and females. Transformation to myelofibrosis, much higher risk for males at 24% compared to females at 18%. And then transformation to leukemia. This does occur in these diseases at a low level, and we have males at 6.5% compared to females at 2.9%, so about double the risk for males. And then finally, in terms of death, so far in the cohort, we've had more male deaths at 38% compared to female deaths at 23%. These are all highly significant by these p-values. So this is, again, a pie chart to understand we can start with an entity, right, meaning ET, PV, and myelofibrosis. And then after a number of years, a median of 8 years, you can see that the distribution of diseases has changed. People have moved out of ET into PV and myelofibrosis and even into AML. And so this is a function of time and has implications in terms of gender evolution. So when we start to look at the gender influence on risk evolution, I've said that this transformation from ET to PV, well, that does seem to be time dependent, and it also occurs much more commonly in females and exclusively in JAK2 positive individuals with ET. And I think this is concerning for everyone because they feel like, well, gosh, I had ET and then I developed PV, and did I have PV all along, or was everything wrong back then? And no, it's just that this is a natural occurrence. It's something that we'd like to prevent, but again, it's no one's fault that it occurred, or there was no misdiagnosis. And similarly, ET to myelofibrosis, and that's a function of time, more common in males and a consequence of older age and probably other mutational events. We've talked about PV to post-PV myelofibrosis. Again, that's a function of time and how much JAK2 gene dosage you have, and I think that'll be talked about later in the thing. And then MPN to AML, we talk about older age, disease duration, and male sex seems to be an issue. Uh-oh. And then finally, are we okay on time? Okay, I'll just keep going. 2 more minutes, okay. So we also talk about survival. These are diseases where natural history is measured in decades, and this is from the Mayo Clinic, doing a huge retrospective study of survival. This was the normal population in black, ET patients in red, PV in green, and myelofibrosis in blue. And you can see that their median survivals were in decades, and ET patients maybe not even that far off the normal population. We had an opportunity to look at this now really adjusted model in our cohort, and this is the cumulative survival adjusted time since diagnosis, and you can see females and males separate significantly again, so that the females, our median survival for females with MPN is about 25 years, whereas males with MPN is about 10. So again, these gender differences play out in every aspect of the disease. So I just want to finish by saying the genetic basis informs the disease type and natural history. We've talked about the driver lesions and the unique diseases they subtend. I don't know why this is. We have to really do a global risk assessment for disease-specific factors and patient-specific factors, as Dr. Michaels already mentioned. And then really for us here today, women carry a different MPN burden. Why is it more common? Why younger at diagnosis? They have longer survival and longer time of exposure and symptom management. So, right, you're going to be living with these diseases. Great, that's great for a long time, but we have to try to assuage that burden and understand really what we're in for in terms as we think of other therapies. So therapies have to address both short-term and long-term goals. And then finally, this disease presentation outcomes influenced by gender. What are the mechanisms of this? And people always ask me, and I think we'll talk in smaller groups. People always want to know about hormones, or there must be a hormone basis to this. And we'll talk about some of the ideas that we're generating. And I think important for us as a group and for the MPN Foundation and all these burden projects, will this gender difference influence responses to therapy? And I think in every sequential clinical trial we do, we have to take females and males totally differently, right? We would never lump heart disease patients in response to therapy now as all comers. We take males and females separately because we know heart disease is influenced by gender, and we have to do this for MPN. So I want to leave with a picture of my hospital. It's the 125th anniversary this year of the founding of the Hospital and School of Medicine. That building still exists. In 2012, we built a new hospital, and it's beautiful. I really want to thank everyone for being here today and letting me present these data and discuss with all of you. Thank you.